today's presentation. Today I am going to present one of my research work which is recently published in Fortune Journal of Health Science. The title was The Right Ventricle Free Wall Stent to Detect Proximal Right Coronary Artery Lesion in Patients with Acute Inferior Myocardial Infarction. So we all know that approximately 40% of all myocardial infarction involves in the inferior wall, and 50% of patients with inferior wall are due to occlusion of RCA proximal to the right ventricular branch, and which is manifested by right ventricular free wall dysfunction, and it is associated with 2.6% increased risk of mortality and increase the secondary endpoints of morbidity regardless of LV functions. So the early recognition of RV dysfunction in patients with acute inferior MI can guide specific therapy like aggressive primary PCI and with particular attention to the RV branch revascularization. We usually use the conventional echo parameters like tricuspid annular pain, systolic excursion, fractional area change, or tissue Doppler imaging to detect the RV dysfunction, but they all have some limitations and may be insufficient regarding the prediction of the level of RCA occlusion. On the other hand, the echocardiographic assessment of right ventricular free wall stent shows subclinical RV dysfunction in patients with proximal lesion of RCA. Among the RV stent, right ventricular free wall stent might accurately assess So among the RV stent, right ventricular free wall stent might accurately assess RV hemodynamics and to predict the adverse clinical events in patients with acute inferior MI. So what was the objective? The objective was to determine the validity of right ventricular free wall stent detected by speckle-tracking echocardiography for identifying proximal RCA lesion in acute inferior MI. It was a cross-sectional observational study which was conducted in Department of Cardiology of National Heart Foundation Hospital and Research Institute, and I am very much grateful to Professor Dr. Tuin Haq Madam for his tremendous support and guidance. So the main inclusion criteria was symptomatic acute inferior MI, and the main exclusion criteria was patients having LCX dominance in coronary anatomy, previous history of any intervention or MI, a lesion more than 50% in LAD and LCX artery, and any hemodynamic instability like cardiogenic shock or arrhythmia, concomitant moderate to severe valvular pathologies. So considering the inclusion and exclusion criteria, 80 patients are selected having acute inferior MI. After admission, we have gone through 2D stent echocardiography, and then patient underwent coronary angiogram. After angiogram, they are divided into two groups. Group 1 includes patient with RCA occlusion proximal to the right ventricular branch, and group 2 includes patient with RCA occlusion distal to the right ventricular branch. And during echocardiographic examination, we have done the normal conventional echo parameters like TAPC, fractional area change, and tissue Doppler imaging. And during 2D speckle-tracking echocardiography, we used a Vivid E9 echo machine, and stent analysis of all RV segments were done. Right ventricular free wall stent analysis using 3 segments of right ventricular free wall was calculated. So among the 80 patients, 47% patients found proximal RCA occlusion and 33% found distal RCA occlusion. There is no significant statistical significant difference found between these two groups in regards of normal conventional echo parameters like left ventricular ejection fraction, TAPC, fractional area change, or tissue Doppler imaging. But stent RV free wall stent shows a significant statistical difference in this two group. The group 1 shows mean average right ventricular free wall stent minus 12.21, and in group 2 it found minus 18.16. After putting all the values and constructing a ROC curve, we found a average cutoff value of minus 15.8 for right ventricular free wall stent to detect proximal RCA lesion, which has a sensitivity of 83% and specificity of 75.8%, which is much higher than the conventional echo parameters. Here is one of the echo pictures of one of my patients, shows normal conventional echo parameters, but RV free wall stent reduced to minus 12.2%. And coronary angiography reveals proximal artery lesion. So in conclusion, we can say that decreased right ventricular free wall stent is a predictor of proximal artery lesion in patient of acute inferior MI, and it can impair without any impairment of other parameters. The decreased right ventricular free wall stent might be associated with increased morbidity and mortality in this patient group. And our recommendation is we can done right ventricular free wall stent to detect proximal artery lesion in acute inferior MI patients, and can help in early assessment and effective management to reduce significant morbidity and mortality in this patient group. This study was published in Fortune Journal on May 2023. Thank you. Thank you.
Thank you for your nice presentation.
Yeah, wonderful presentation. I agree the strain echo is very useful to identify the RV wall motion abnormality. However, you showed the sensitivity and specificity is not perfect, around 80%. What is the reason why another 20 or percent miss to identify the proximal RCA occlusion? What is the cause of the misdiagnosis?
So because it may the timing of presentation may affect the result, and also we couldn't do the echocardiography in timely manner, because some patient admit in within 10 to 15 minutes after development of MI. So this may affect the result.
Does the RV infarction is related to this sensitivity? Because if you compare with MRI or other technique, you can identify the RV infarction.
Sir, we can use MRI, but in a country, poor country like us, MRI is much more expensive, and people couldn't do this, and it is also time consuming MRI. So it is the most feasible and
one question: were the echocardiograms done before the angiogram or after?
Yeah. Echocardiography done after patient admission, just after admission of the patient.
Before the angiogram was done.
Yeah, before.
So this patient, this group of patients also having some involvement of the LCX and LED. How much
No,
percentage
so
of
that was our exclusion criteria. If the LED and SCX is more than occlusion of LED and SCX more than 50%, then we exclude the patient, because that may hamper the stent analysis.
you are considering that this patient have subclinical RV dysfunction, but we think that this patient should have subclinical RV dysfunction. So how will you define subclinical RV dysfunction in a patient of inferior MI with RV involvement?
So usually when the RV dysfunction is observed, then other conventional parameter can reveal that. But subclinical RV dysfunction, other conventional parameters like TAPSI, fractional reactions, they couldn't detect it, but stent can detect it.
Thank you. A nice discussion. We're moving to next speaker, Dr. Mahmood Hassan Khan. He will talk on emergency management of chronic